Namaskar. Welcome and welcome and welcome to this series of Masterclass which we have, and this series of Masterclass has been specially crafted for you. The most important, I would say, entities for anybody to have a pregnancy are three things: the ova, the sperm, in fact the embryo, and the endometrium. So this could vary in every human being, and to have a pregnancy naturally with IUI, with IVF ICSI, we need to optimize the sperm and the ova. So Dr. Jatin and I were one day just talking to each other, and we decided to have a masterclass. And a masterclass where we have a series of lectures on how to optimize the ova and the sperm for a natural pregnancy and IUI, 1, for IVF ICSI, 2, and what lifestyle modifications can we suggest to our patients, and how lifestyle affects the ova and the sperm in a very holistic manner is the third. And I welcome you to the second masterclass on optimizing ova and sperm in IVF ICSI. It starts now.
I welcome you all to the webinar series conducted by Intas Women Health on optimizing gametes. Today's webinar is on optimizing ova in IVF and ICSI, given by eminent faculty Dr. Jatin Shah, and second, that is optimizing sperm in IVF ICSI, given by eminent faculty Dr. Jindal. Dr. Jatin Shah is MD, DGO, Gold Medalist, Director, Mumbai Fertility Clinic and IVF Center. He has helped to establish more than 20,000 IVF pregnancy over 3 decades of his ART practice. Dr. Jatin Shah has pioneered the setup of IVF centers and practice of batch IVF 20 years ago in India. He has presented more than 500 presentations, keynotes, guest lectures and webinars in international and national conferences. He has to his credit numerous awards like Dr. Adi Dastu, Dr. C.N. Purandare, Dr. Indumati Javeri prizes, JC's Young Personality of the Year, Top Dogs Mumbai, India Today. He is also a founder member of Aspire. He has written numerous text chapters and publication in esteemed journals. His area of interest are failed IVF, implantation, obstetric outcomes in ART, progesterone levels and frozen transfers, use of GCSF and PRP for RIF, and third-party ART. This is a short introduction of Dr. Jatin Shah. I welcome you, sir.
Thank you so much, dearest Dr. Sonal.
Let me introduce Dr. Jindal, sir, also. Dr. Jindal, Dr. Jindal is the Scientific Director of Fertility Center at Jindal Hospital Fertility Center, Vice Chairperson, Delhi ISAR, Delhi IAGE. He has received Gold Medal of Best Postgraduate MAMC, New Delhi, 35 awards from different organizations, collaboration with multiple institutions for research, including American Center of Reproductive Medicine, national and international offline and online master trainer. He has many publications, chapters in 8 textbooks on fertility, over 200 national and international presentations. Special interest is in fertility enhancing endo-laparoscopic and microscopic andrology surgery. Special interest in surgical, medical, and laboratory andrology. With this, I welcome you, sir, Dr. Jindal, sir. And now, yes, I welcome Dr. Jatin, sir, to start his session. Over to you, sir.
Thank you once again, Dr. Sonal. Dearest friends, it's always such a huge pleasure to be a part of any academic platform. Division of course, I must thank my distinguished co-speaker, Dr. Sunil Jindal, for putting together the program of this meeting and making such interesting topics to enthrall the audience. We did a few days ago last week for the Foxy platform, and today we are doing it for the IVF group. The main topic for today is going to be how to optimize your ova for IVF and ICSI. And in this, we not only talk about ovarian stimulation, that is of course understood it to be part, but what about all the adjuncts? What about all the pre-treatments? What about your choice of analog? What about agonist versus antagonist? And it doesn't end with optimizing the ova, The final endpoint is, of course, once Sunil completes his presentation, optimize the sperm to then get the best embryo with the highest potential for implantation and give the patient a healthy live birth. So we have to optimize the ova, but then we have to make sure that the ova and sperm are treated carefully, handled carefully in the lab to give you good embryos. And all your efforts as the clinician should not go to waste if something goes wrong on the embryology side. So let's begin then that how do we go about optimizing your quality of the oocyte. We all know that oocyte competency and sperm competency is very important and the key to good embryo potential. We know that the oocyte is the major determinant of embryo developmental competence. Not only does it deliver half the chromosomal complement, but also a lot of the mitochondrial genome, the maternal mitochondrial goes to the embryo. And we know that besides the paternal genome, the maternal genome, unlike the maternal genome carries a heavy footprint of parental aging. So elderly women and aging women will have a more disastrous effect on the maternal genome and also the mitochondria in the oocyte. So it's very important to focus not only on genetic and chromosomal competency, but also to focus on mitochondrial competency of the oocyte for perfect embryos. What about the correlation between number of oocytes obtained and oocyte competency? There were initial reports that, if you get too many oocytes, then you have a higher incidence of aneuploidy. We now know that that is no longer true. And we know that the more oocytes you get, the more embryos you get, and the higher the number of embryos, the higher will be your pregnancy rates. This was, of course, Sankara's classical study, which showed us that when you are thinking of fresh embryo transfer, the ideal number of oocytes to be retrieved is between 5 and 15 when you get the best pregnancy rates with fresh embryo transfer. But now this is a thing of the past, and we know now that in 2021, where do we stand? We are targeting many more oocytes. The aim today is to have one good ovarian stimulation cycle. Aim 25, even 30 oocytes, so that you have enough top quality euploid embryos for vitrification, thereby giving you a very high cumulative live birth rate when you consider several frozen transfers which can be offered to the patient. At the same time, of course, we want acceptability in terms of number of injections. We want to keep it cost effective. We want to keep it absolutely safe. And we want 100% OHSS free clinic. So gone are the days when you could have one protocol to suit all. In fact, now, if you come to our clinic and pick up any 10 files, all 10 will have different stimulation protocols for an individual patient. So you have to take into consideration a lot of factors so that you can fine tune your stimulation to such an extent that you get the best outcome for any given patient. So this study here from 2019 was a very interesting study because it showed us very clearly, and it was almost 300,000 IVF cycles, that the group with the most number of oocytes aspirated had the most number of top quality or good quality day 2 and day 3 embryos. And what are the number of eggs that you need to get top quality embryos? And you can see here that if you want more than one top quality embryo, one or more, you need at least 3 or more mature oocytes. If you have 3 mature oocytes, you are likely to get one top quality embryo and so on. So you can see here that when you talk of mild stimulation or natural cycle IVF, one oocyte or 2 oocytes, you may not really achieve your goal of those top quality embryos. And you don't want just one, you want many more top quality embryos for high birth rates. What about our heavy dependence on and embryo quality that embryo developmental potential? So we know that it cannot be used as quality. It may be a guide to your oocytes, the ovarian reserve, and what is the likely number of oocytes that you are going to patient. What about the agonist versus the antagonist? Now, almost a decade ago, when the antagonist was introduced, purely to avoid OHS responder group, most of us shifted completely to the antagonist for all our cycles. And we forgot all the advantages that the long agonist protocol gave us in the good old days. Low throughout stimulation. Very important to get competent and optimized. synchronized follicular development. So all your follicles will be in the same range. If you have 20 follicles, you're likely to get 18 or 19 metaphase 2s. And also you will get a higher number of oocytes and top quality embryos with the agonist. Now these two are a definite advantage in normal and most poor responders. I agree that in high responders, you should never use the agonist protocol because you will end up with OHSS, and you do not have the flexibility of using an agonist trigger in the long agonist protocol. So you have to be careful in case selection and make sure you apply the agonist properly in your clinical practice. But now, does it really have any advantages over the antagonist? And what is the impact, since we are talking today of optimizing oocytes? Do the analogs have a direct impact on oocytes and embryo quality? And you can clearly see here in this study, with the agonist, you get more follicles, you have higher number of retrieved oocytes, but more importantly, you have a lower number of oocytes with cytoplasmic abnormalities. And this is what we are looking out for, especially in the poor responders. Again, you can see here, number of fertilized oocytes significantly higher in the agonist group, and number of zygotes with a normal pronuclear morphology, again, significantly higher in the long agonist protocol group. So these are all the advantages that the agonist will have on your number of oocytes, number of fertilized zygotes, and also you will have higher clinical pregnancy rates, especially important in the poor responder group. Here again, you can see a study from 2019 comparing the antagonist and agonist in fresh transfer IVF cycles. And again, you can see statistically significantly higher number of oocytes, higher number of zygotes, higher number of embryos, clinical pregnancy rate much higher at almost 58% as against 32%. Live birth rate also almost double at 46% versus 24% with the antagonist. So we have so much evidence that maybe it is time to reconsider using the agonist for a lot of your patients, especially your poor responders, and a lot of normal responders who have an AMH of say less than 2.6 or 2.7. Now, this was a study to demonstrate, to actually compare that does the agonist and the antagonist give different outcomes in clinical practice. And the best way to do this is to compare the two in the same patient. You know, most studies will take 500 patients with agonist, 500 patients with antagonist, but they're different patients. So here they compared the two in the same patient. So they switched between the agonist to the antagonist in consecutive cycles. But mind you, responder patients, the study was done using the agonist cycles were done using only pure FSH, like FSH, and no LH was given to these patients. As expected, they found no difference in the number of embryos with top quality in the agonist and the antagonist group in the same patient when they did it in this fashion. We did it with a slight difference because I always believe that with the agonist, you completely cut off endogenous LH, and a little bit of LH is probably important to get optimal estrogen levels and top quality oocytes and embryos. So we restricted our study to poor responders, especially Poseidon's group 3 and 4. Most of them were in different age groups, mostly in their mid-30s. AMH, of course, was low. 50% of them had an AMH of less than 1. And there were 36 patients, first cycle done with antagonist or the agonist, and the second cycle done with the other analog. And what did we find? The only difference compared to the study I showed you earlier, instead of pure rec FSH, we used HMG in the agonist arm. And this was to supplement LH from the beginning. In fact, we preferred HPHMG, which had HCG-driven LH activity. And you can see here significantly higher number of oocytes, significantly almost double the percentage of top quality embryos. And that, to my mind, is the most important difference, which makes the difference between success and failure in a poor responder patient. So you can see here almost double the percentage of top quality embryos when you use the long agonist HMG protocol in a poor responder. What about normal responders? And here we have this study from Lembach 2017, again comparing the agonist and the antagonist in normal and all general populations of IVF patients. And they further stratified the patients into several groups. They compared flexible start antagonist. That means you start at 14 millimeters, the antagonist, versus the long agonist. They compared a fixed day start, means you start on day 5 or day 6 of stimulation irrespective of follicular size, versus the long agonist. They compared OC pill pre-treated flexible antagonist versus the long agonist, and OC pill pre-treated fixed antagonist versus the long agonist. So they clearly differentiated all the groups as to which gave you the best outcome. In general, they found the clinical pregnancy rate was lower with the use of the antagonist. And this is very important because it's a huge trial covering 35 trials and almost 8,000 couples. They also found that the agonist protocol yielded significantly more oocytes, which is very important because in a poor responder, we know that every additional oocyte that you get will improve your live birth rate significantly. They also found that when there was OC pill pretreatment and you started the antagonist at 14 millimeters instead of a fixed day, the pregnancy rates were much lower with the antagonist protocol as compared to the agonist. They also found that if, on the other hand, you had a fixed day start antagonist, that is usually day 5 of the gonadotropin or day 6 of cycle, and you did not give OC pill pretreatment, then your pregnancy rates between antagonist and agonist were the same. So these two minor points have now become very huge in determining success or failure between the agonist and the antagonist. So what you need to remember is that if you are to achieve all the goals of the agonist protocol with an antagonist, then you have to make sure that you, of course, give some form of pretreatment, either with estradiol or progesterone or antagonist. Do not use OC pill pretreatment. Have a fixed day start antagonist. So don't wait for 14 mm. Mark my words, for patients with regular cycles. So these are not PCOs, not anovulatory patients. All your normal and poor responders with regular ovulatory cycles ranging from 26 to 30 to 34 days, you will have a fixed day start antagonist. You will have a flexible day start for your anovulatory patients because there you do not know when they will begin to respond. You start with 150, you assess after a week, there's no response. You step up to 225. And then when you see the beginning of a response, say multiple follicles of 12 mm, is the time you could start the antagonist in this group of patients. So you need to fine tune your treatment to this extent so that you make sure that you optimize the final oocyte quality that you get. Let's talk a little more about the high responders. Just some fine tuning points. I'm not going to tell you details of treating the high responder, but since we are talking of optimizing the oocyte, what clinical tips can I give you? We know, of course, there is no, it's a no-brainer as to which analog to use. For all high responders, you have to use the antagonist protocols. It would be quite criminal if you use the agonist protocol and she ends up with hyperstimulation, which she will. So strictly antagonist protocol, strictly agonist trigger if you have more than 15 follicles. And since most of them will have more than 15 follicles and you would have given the agonist trigger, you would have a deficient luteal phase. So you would need to do a freeze-all and then do a subsequent frozen transfer in the next cycle. Now here, as I told you earlier, we knew from the Brussels Consensus Workshop way back that the fixed protocol appears to be associated with a higher pregnancy rate, but this was for patients with regular cycles. So very important, as I told you earlier, for patients with regular cycles, you do the fixed, but for patients with PCO and high responders, flexible start is much better than the fixed. That means you only begin when you start seeing a response. Multiple follicles in the range of 12 mm or a lead follicle in the 14 mm is when you should start in PCO patients. And you can clearly see when you compare the flexible group to the fixed group, in PCO patients, significantly higher number of oocytes, higher number of metaphase oocytes, 11 versus just 4.5, and much, much higher number of frozen top quality embryos, almost 9, as against just 2 with the fixed day start of the antagonist. So this is how you need to be very careful. Don't tell your juniors, oh, when she's 14 mm, just start the antagonist. That doesn't hold true for all categories of clinical response. Another very important tip in high responders, if you don't want disaster, is do not use OC pill pretreatment even in these patients. Because you can see here, prolonged OC pill pretreatment will cause excessive suppression of endogenous LH. And these are the patients who will need the agonist trigger. And the agonist trigger is based on the principle that it releases endogenous FSH and LH in a form of a natural physiological surge. But if you've depleted the endogenous LH completely, almost 50% of your cycles will have a suboptimal response. By that I mean you will have 20 follicles, but you'll get 10 eggs. You might have 10 eggs, but only 3 will be metaphase 2s, and so on. So that is what happens when you use an agonist trigger in an antagonist cycle with prolonged OC pill pretreatment and LH suppression. So you need to be very careful of this part too. What about the choice of gonadotropin? Which gonadotropin should you be using for the high responders. We've always been taught that you need pure FSH, these patients don't need LH, and so on. But we now have a trial, the MEGASET trial, which compares HPHMG, that's the blue arm, versus REC FSH, that's the black arm, for PCO and high responders. And they found in the fresh cycles, the ongoing pregnancy rates were on par, although there was a tendency to a slightly higher pregnancy rate with HMG. Surprisingly, live birth rates were also on par, proving non-inferiority of the HPHMG. But what was most remarkable was a reduction, almost half, the early pregnancy losses, which we so commonly see in PCOS, not usually genetic, but more often due to mitochondrial defects, which are seen in PCO patients. So what did the trial show? That you will get 7 fewer eggs with the HMG, which is expected because REC-FSH is more potent and obviously gives you higher number of oocytes. This translates to 5 fewer metaphase 2s, translates to 4 fewer zygotes, translates to 3 fewer blastocysts. So then where is the advantage? But there is no difference in the number of top quality or excellent blastocysts, which is the same. So this is the advantage, that when they further compared the frozen embryo transfer outcomes. Now, mind you, in the frozen transfers, very interestingly, all the embryos were PGT tested and only euploid embryos were transferred. And yet, there was a higher live birth rate with HPHMG as compared to REC-FSH. And you can see here, cumulative early pregnancy loss, again, half of what you get with REC-FSH. And if you put together fresh and frozen, again, significantly lower early pregnancy losses. And this seems to be the biggest advantage, that although embryo to embryo, they are both euploid and genetically the same, what explains the lower pregnancy loss with the HMG group embryos? So obviously there is some effect of this LH on the competence of the oocyte and the implantation potential of the embryo, which reduces the early pregnancy losses. And you can see that the cumulative live birth rates again were on par, that is the pregnancy rate after all the transfers done within 6 months. But this cumulative live birth rate in 6 months was achieved with fewer transfers. 43 less transfers were done in the HPHMG group, using 65 less euploid PGT tested embryos. And this is a huge advantage and a huge breakthrough rather paper which has come in the last year, which really changes our entire thinking about how to use gonadotropins for PCO patients, whether they need FSH or should we be adding LH for these patients. What about normal responders? Here it's very important that do not convert a normal responder to a poor responder by a wrong choice of your initial dose. Please do not go below 225 for any patient. A minute a patient is for IVF or ICSI and you are on your antagonist protocol, 225 should be your minimum starting dose across all groups. And you can see here significantly higher number of oocytes with 225 versus 100 versus 150, but no difference if you then step up to 300 for a normal BMI, normal endocrinologically normal, young normal responder. So 225 should be your standard starting dose. Some of you might think, though, let's start with 150 and then I'll decide on day 7 and then increase the dose. But increasing the dose later on doesn't really help to increase the number of metaphase 2s and viable embryos. And why is this? You can see here, you have given 225 a day and it takes the 7 days for it to reach its threshold or exceed the threshold when recruitment begins. And on day 7, you then decide to do a scan and decide on the further dosing. But remember that when you increase the dose on day 7, you already have recruitment of these few follicles, which have grown from 2 to about 12 mm, sometimes 14 mm. On day 7, you now want to increase your dose thinking that, oh, there are just 4 follicles of 12 mm and I was expecting 15. And then you increase the dose over here. But remember, it takes another 3 days for that new dose to start new recruitment. So 3 more days are gone. So you're already on day 10 when you have recruitment of some new follicles. But by that time, these follicles, the first 4, are already reaching their 18 millimeters and ready for the trigger. So when you do this, any new recruitment that you get on day 10 will not achieve maturity until day 18. And you're not going to wait until day 18 because these 4 are ready and you have to give the trigger on day 11 or so. So this is the whole point, that the initial starting dose has to be correct, and increasing the doses midway during the cycle are of no use to increase the number of competent oocytes and optimized oocytes that you get. What about poor responders? Now here it's very important that when you are using an antagonist protocol and you know it's a poor responder, you want a perfectly synchronous cohort. If she has 4 follicles, you want all 4 to be metaphase 2s. And that is why pre-treatment is very important. So luteal estradiol was a favorite for more than a decade, 2 milligrams twice a day from day 25. She will not get her menstruation at the regular time because this dose is inadequate to stop menstruation, unlike an OC pill. And when she comes to you, you can then push the stimulation by even a week if you want to schedule or avoid a weekend and so on, because this will suppress the dominant follicle but not suppress menstruation. So she comes in on day 2 or day 3, and whenever you want to begin day FSH, anytime until day 9, that is the day you can stop the luteal estradiol, or you can even continue it, as some studies show, until the day of HCG. Norethistérone, often used, again, minimum 7, maximum do not exceed 15 days, again to avoid oversuppression. OC pills, totally avoidable. If at all you have to use, not more than 10 to 12 days. But the best seems to be the antagonist. And we normally give it on days 2, 3, and 4, and then begin stimulation from day 5, so that you get a perfectly synchronous cohort and you don't have one follicle racing ahead and becoming dominant. So you can see here how estradiol valerate is used. And this is cycle day 1, 2, 3, 4. And I do not want to begin, say, till day 8 because I'm going out on a vacation. I just continue estradiol. There will be no follicular recruitment. Then begin your FSH and stop the estradiol a day before, or continue it until the day of HCG. And you can see, why did I say continue? There was a study here which showed that if you continue, the pregnancy rate was 27%. If you stop, it was around 20%. So there's no harm in continuing, and there may be a marginal benefit on the endometrium if you continue this small dose of estrogen throughout the stimulation. This was, of course, norethistérone, as I told you. Start around day 20 of the cycle, minimum 7 days, maximum 14 days. Stop on any Sunday in between. Expect menstruation on Thursday and begin stimulation on Friday. But antagonist, as I showed you, why it is so important in a poor responder, as Blockheed study showed way back in 2011. You can see here, when you give antagonist on day 2, 3, and 4, and then begin stimulation from day 5, the only statistically significant difference was the number of oocytes. You can see it goes up from 10 to almost 14. And this is hugely important in poor responders, because if you are going to get even 1, 2, or 3 more oocytes with this kind of pre-treatment, you are greatly enhancing the live birth rate for that patient. Why did I say no for OC pills? You can see a lot of evidence, 2006, slower growth, longer stimulation, higher consumption of REC-FSH, 2017, lower pregnancy rates, lower live birth rates, as recent as 2018, higher miscarriage rates in OC pill pre-treated groups. So please avoid prolonged OC pill pre-treatment for any category of patient. Again, you can see, I already showed you this slide before. What about agonist pre-treatment for Poseidon's 3 and 4? Now, 3 and 4 are groups who, the poor responders, we know, were young and old, who start with a decreased ovarian reserve. And again, you can see Huang study in 2018, which clearly showed that the agonist was more effective in terms of lower cancellation rates and higher live birth rates. And you can see here, almost double the live birth rate with the agonist as compared to the antagonist in Poseidon's group 3, that is young patients who start with a diminished ovarian reserve. And clearly, there was a great benefit in using the agonist protocol. There are different types. Again, optimizing the quality of the oocyte also depends on the trigger that you use. Many a times you have a lot of follicles but don't get a good number of oocytes. Sometimes you have a lot of oocytes but you get less than the anticipated number of M2s. And sometimes you have adequate M2s but you get less top quality embryos. And that is why a dual trigger is often helpful for most of your normal and poor responders. Remember that when you look at a natural physiological menstrual cycle, the final oocyte maturation is induced by an increase of not only LH. When we give a HCG trigger, we are only simulating LH, but you also have an increase of FSH. And this is what the agonist trigger does, that it induces a more physiological peak and induces both LH and FSH flare-ups or surges. So you can see here, in patients who had a low number of oocytes compared to the number of follicles that you had, when you switched from HCG to the dual trigger in a subsequent cycle, you had a significant increase in the number of oocytes retrieved, number of top quality embryos, and ongoing pregnancy rates. The same for patients who had a low proportion of M2 oocytes compared to the number of oocytes retrieved in a previous cycle. Again, when you switch to the dual trigger, by dual trigger we mean HCG as well as the agonist, you have a significantly improvement in all the parameters, especially ongoing pregnancy rates for this group of patients. And what about poor responders? And very recent study again comparing just HCG versus the dual trigger, that is HCG with the agonist, and you can see an increase in the fertilization rate, increase in clinical pregnancy rate, lower abortion rates, and much higher live birth rates with the use of the dual trigger, even in women with a diminished ovarian reserve. So it's very important to fine tune your triggers. What about normal responders? Again, we have a study from 2020 showing higher number of top quality embryos with the dual trigger as compared to agonist alone or HCG alone. And this would obviously give you more attempts and therefore a higher cumulative live birth rate. Coming to the next interesting area, that is the use of adjuvants, because all of us have been using DHEA and all kinds of adjuvants. We know that with increasing age, testosterone levels will reduce in most women. And we know that this is very important point because when you look at follicle development, right from the primordial to the pre-antral to the antral and to finally giving a mature oocyte, you have androgen receptor expression and androgen requirements at every of these important stages. So it's very important because androgens help in promoting follicle initiation, pre-antral development, antral development, and final oocyte maturation. So of course, all of us used a lot of DHEA for almost a decade, and we had so many preparations available to us in the market. In fact, it was just a pickup drug at any health supplement shop without even a prescription. But we now have some large RCTs, 3 large RCTs, which show that maybe DHEA is not as effective as we thought it to be. And that brings us to something which is much more promising, and that is the Transdermal Testosterone Gel. So if you look at testosterone now, again, most of the available studies which are on the PubMed are giving testosterone for a duration of just 2 to 3 weeks, that is 15 to 21 days pre-ovarian stimulation. But if you look at physiology, and as I showed you in the slide earlier, it's the 71-day process of conversion of a secondary follicle to an antral follicle. So you need androgens and testosterone for the whole 60 to 70 days if you are to get its best effect in improving oocyte competence. Some papers here in 2014 again showed that testosterone treatment for 3 to 4 weeks pre-stimulation increases antral follicle count and ovarian stromal blood flow, thereby improving the response to COS and also resulting in a decrease in the FSH dose. We also had numerous publications coming in now showing increased number of oocytes, better number of embryos. Again, here you can see a meta-analysis clearly showing improvement in all the outcomes with the use of transdermal testosterone gel. Of course, the most important will be the T-Transport trial, which is actually giving the gel for the whole 60 days pre-stimulation, followed by the long agonist protocol, as I told you, which should be the treatment of first choice for poor responders. And as I told you earlier, they are also using HMG and not pure FSH for this trial, so that we get, and comparing it to a placebo for 60 days to exactly know the effect of the transdermal testosterone. Initial, although it's not yet published, but initial reports are very encouraging. And I think we will soon, all of us, be prescribing a lot of testosterone gel. Since we are on the topic of androgen, again, there is a recent paper which caught my attention, and that is the use of letrozole. We know letrozole also is an androgen modulating agent. By being an aromatase inhibitor, it blocks the conversion of androstenedione and testosterone to estrone and estradiol, thereby increasing the local androgen levels in the ovaries. So how does prolonged extended letrozole use? That means if you were to give letrozole for the entire follicular phase, especially for elderly patients in their late 30s or early 40s, would this be a benefit for the number of oocytes and embryo quality? And here we have a study which compares 5 milligram letrozole from the first day of stimulation until the trigger day, as you can see here. And this was the gonadotropin alone group, and this was gonadotropin with letrozole 5 milligrams from day 2 until the day of HCG. As expected, estradiol levels significantly lower because of the aromatase inhibition, but this actually becomes an advantage if it's a fresh embryo transfer cycle, because we know that most of the fresh transfers fail because of supraphysiologic estradiol levels altering endometrial receptivity. and that is countered when you add letrozole to gonadotropins. But what is more important, significantly, almost a doubling of the number of oocytes, number of metaphase 2s, number of zygotes, number of top quality embryos also up from 1 to 2.35, all statistically significant. So very important that maybe this could be a good ray of hope for a lot of poor and suboptimal responders who constitute almost 50% of our patients in current IVF practice. What about oxidative stress? Now, this is an important area because we know that stress-induced impairment of oocyte developmental competence involves alterations in mitochondrial function, which are caused by an increase in ROS, and that brings us to coenzyme Q. Of course, we had a meta-analysis which says that very low or low quality evidence to show that taking an antioxidant may benefit subfertile women. But this was in general across all groups, that is high responders, normal responders, poor responders. If you actually look at Poseidon group 3, that is your young patients, which low AMH and low AFC, we have a study here from 2018 which clearly shows and which only assessed the number of high quality embryos, and they found higher estradiol, lower cancellation, higher number of oocytes, higher fertilization rate, most importantly, more high quality embryos, which is always the end point to get the best cumulative live birth rate for NEF IVF cycle. What about vitamin D? Again, clearly the meta-analysis shows significantly lower live birth rates in women with deficient level of vitamin D, and therefore it's mandatory that you support or supplement vitamin D right at the outset before you begin your stimulation cycles. Zinc supplementation also is found to be beneficial, especially in improving the meiotic competence of maturing oocytes. And very interesting paper here. Till now, we have been using myoinositol only for PCOS and high responders. What about myoinositol for improving oocyte competence in normal and poor responders? And we now have a study which compares this across all groups, and they found better oocyte quality, embryo quality, and clinical pregnancy rate was significantly higher with a couple of months of pre-treatment with myoinositol, even in normal and poor responders. Significantly lower miscarriage rates with the myoinositol supplementation, higher number of grade 1 embryos, lower number of GV oocytes, and less consumption of rec FSH and gonadotropin in the myoinositol group. So you have a lot of studies here, right, from 2009, 12, 15, and 17 showing benefits, and this is definitely worth a try as to whether we should use this for all our patients to get better outcomes and more top quality embryos for freezing. What I'm really excited about in this year has been the dual stimulation for poor responders. We know that dual stimulation means you do 2 stimulations. Within a month, you have a follicular phase stimulation and a luteal phase stimulation so that you maximize the number of oocytes obtained and you get many more top quality embryos, especially in very poor responders, like this group of patients that we did our initial study on, 28 patients, different age groups, all had very low AMH levels. Follicular phase stimulation done with a combination of rec FSH and HMG. Total dose is 300, sometimes 450 for high BMI. Fixed day start antagonist and agonist trigger. No HCG trigger because you have to do the luteal phase stimulation. Again, luteal phase with the same stimulation starting 2 or 3 days after your egg retrieval. Again, the fixed day start, again the DECA, but here you could give an HCG trigger because you don't plan another stimulation immediately thereafter. Embryo transfer was done with either the FPS embryos or the LPS embryos, whichever were of better quality for that given patient. Clearly, we can see with the luteal phase stimulation, somehow you have almost double the proportion of top quality embryos as compared to follicular phase stimulation. Only 4 out of 20 patients who reached embryo transfer had better embryos with follicular phase stimulation. 16 patients had better embryos with luteal phase stimulation. 2 out of 4 conceived here. This was unbelievable, 13 out of 16 pregnancies. Of course, we had subsequently 2 miscarriages, but still that gives you a reasonable pregnancy rate in the range of 65% for this very difficult group of patients. Of course, the numbers are small, but I'm sure that even when we touch 100, even if this stabilizes at say around 40% live birth rate, I would be really happy for the Poseidons group 3 and 4 who still have a huge ray of hope of having their own biological child. But what are the challenges for dual stimulation? That do you need to give the antagonist in the luteal phase? Can you use medroxyprogesterone acetate as an alternate to the agonist antagonist throughout? What is the best day to start the second stimulation. Different studies report an interval of 1 to 5 days. What will trigger and whether you should use higher dose of gonadotropin or HMG should be used in the second half, all are under investigation. But I'm sure in another year or two, we'll have a lot of publications showing us whether dual stim is the way to go for these patients. LH supplementation, of course, we know all elderly women should receive it from day 1. All hypo responders where the follicles become stagnant on day 6, day 7 must have LH added. And poor responders, there was a controversy, but now the same groups admit that addition of LH will increase your pregnancy rates to the tune of 30% in poor responders. So current recommendation, to summarize what we do: coenzyme Q, resveratrol, ARG9 for a couple of months, testosterone for 20 days pre-stimulation. Long agonist is my first choice with HMG 300 to 450. Estradiol or antagonist pre-treatment if you have to use the antagonist protocol with the dual trigger. Dual stimulation seems very exciting for the future. Fresh transfer if progesterone levels on the day of HCG are normal and you have got your 2 top quality embryos. For any other type of problem, low progesterone, high progesterone, or you don't have enough embryos and you want to accumulate embryos, you must do a good frozen embryo transfer for those patients. Another important area which seems to be promising is, of course, intra-ovarian, the use of PRP, that is autologous platelet-rich plasma injection into the ovaries for poor responders, and you can clearly see improvements in clinical pregnancy rates and live birth rates in the PRP group as compared to the control group. And that brings us to concluding for poor responders that, of course, for Poseidons 1 and 2, pre-treatment with estradiol or antagonist in a subsequent cycle, ensure the correct starting dose of FSH, rule out polymorphisms. If they are present, then use higher doses of FSH or high LH protocols, and judicious use of the agonist and antagonist. Poseidons 3 and 4, avoid overdosing, judicious use of agonists and antagonists, dual stimulation, embryo accumulation, ovarian activation, and if all fails, then oocyte donation. Now, before we end, of course, as I told you earlier, just getting a competent oocyte is not enough, and you have to also take care of all the external factors which could be affecting your final quality of the embryo. And what do we mean by these external factors? So we know that in vitro conditions and a lot of environmental factors like temperature and pH fluctuations can affect maturity, fertilization, fragmentation, cleavage rates, plastulation rates, aneuploidy rates, and multinucleation rates in the oocyte. So you can see here throughout from the oocyte to the embryo, you have operator factors, you have clinical factors, you have laboratory factors, and of course, many other reasons. So if you look at clinical factors, we know that too much of FSH also can cause slower embryo development. So it's very important to give the exact FSH dose. Don't underdose or you will get inadequate oocytes. Don't overdose or you will not get optimal embryonic development. Also, we know here that you can see underweight females, they have significantly slower cleavage as compared to normal women. We also know that in smoking also will cause significantly later cleavage in most embryo developmental events. Polycystic ovary patients, also PCOS, we know they have slower early embryonic development, and they are known to have therefore lower number of top quality embryos. Obesity affects practically every stage, and you can see here reduction in oocyte and embryo quality, reduced progesterone, luteal insufficiency, impaired implantation, increased miscarriage. Even in the men, reduced semen quality, increased erectile dysfunction. All are common with obesity. Smoking also affects practically everything to do with reproduction, causes a reduced ovarian reserve, earlier age of menopause, lower response, higher levels of ROS, greater number of immature oocytes, increased zona thickness, delayed embryo cleavage, increased risk of aneuploidies, and therefore reduced implantation. Alcohol consumption, these are all important because I'm sure all of you now face the same problem in most metropolitan cities. We have more and more young women who are admitting to smoking and use of alcohol and so on. And again, alcohol also affects most of the events which are associated with good reproduction. But what is more important is, of course, laboratory essentials before I conclude. And we know that you need good purifiers, air systems in the laboratory. You need good online filters for every incubator from the gas cylinder, and every time you change a cylinder, you must change the online filter as well. In fact, this is more important than the clean air of the room. Then, of course, you must have state-of-the-art incubators which maintain temperature, pH, and so on. Avoid the conventional incubators. Try to get the desktops which need minimum maintenance and very quick return to temperature and pH, even with frequent But the most important study is the Cairo consensus group, that there is only one thing that is truly important in IVF laboratory, and that is everything. So everything is important. Remember, a lot of times we take granted that somebody must be taking the embryologist, that you are in the loop and you are aware of all these things. So manipulation, your stage temperature, your dissecting, must remember supply gases, buffers, addition of bioactive compounds, selection of right culture media, keeping. You should use single step or sequential, which is better for your points. I totally encourage all of you to please read this article by the Cairo consensus, insight into how finally very strongly about is that most Indian clinics switch to ICSI for all for no justification whatsoever. If you look at the increase clinics to ICSI for all patients, and this is just not justified. Look at the evidence. ICSI does not offer any advantage, no clear benefit, fewer live births, blastulation rates are lower, IVF gives higher pregnancy rates. Then where is the justification to do ICSI for all? Even in advanced age, ICSI was cited as an indication that if the woman is about 35 and has only 5 oocytes, you should do ICSI. In fact, quite the contrary, as this study showed. Conventional IVF gave you a much higher blastulation rate than the use of ICSI for even women of advanced age. And this is because it is operator dependent. You need a highly skilled embryologist. It is time consuming. There is exposure to chemicals such as hyaluronidase and PVP. On an average, 20 to 30 minutes, the oocytes are on the micromanipulator and you don't know the effects of this prolonged exposure and so on. And therefore, it is important not to do that. Of course, this is just one slide, which I'm sure Dr. Sunil also will show us because he's going to deal with the male partner and the use of antioxidants for improving your sperm quality so that you get best top quality embryos. So if your embryologist tells you, okay, the oocytes are not optimized and not optimal, is it game over for the patient? No, not at all. There is a ray of hope. You can see here this paper from 2015, where dysmorphic oocytes, every day your embryologist tells you, oh, there's a dark cytoplasm, or there is a vacuole, or there's a abnormal zona pellucida, or increased perivicline space, or so on. And you get disappointed. But how many of us actually then go and correlate our pregnancy rates with these remarks? And you can clearly would be lower with dysmorphic oocytes, but embryo quality on day 2 and 3 in normal form oocytes and dysmorphic oocytes is the same. So this is very important, and this gives you hope that even if you occasionally see all these abnormalities, all is not lost and you can still achieve a take-home baby for that patient. So you can quality embryos, dark cytoplasm, of cytoplasmic vacuoles. So we come to the end, and this is of course without whom, of course, all these 30 years of work would not be patient. So once again, grateful to Dr. Sunil Jindal and of course Dr. Sonal, Dr. Lay, the entire team.
Sir, with your permission, I will take some questions. Jatin sir, how does OCP pre-treatment change the outcome of fixed versus flexible day start?
No, can you just repeat? I lost that first line.
Right, sir. They are asking, how does OCP pre-treatment change the outcome of fixed versus flexible day start?
Yeah, so they are saying that the OCP over suppresses the endogenous FSH-LH. So that is why you don't get an optimal outcome with when you give OCP pre-treatment and you use a flexible day start of antagonist. So best is to start a fixed day antagonist and not give the OCP pre-treatment for patients with regular menstrual cycles. So that's all your normal and poor responders.
Right, sir. Again, similar question. What is the rationale behind suboptimal outcome of flexible day start compared to fixed day start in normal responder? I think you have already.
No, so the logic, no, it's a good question. The logic is, that the LH surges, we think that the LH surge only comes towards the end of the follicular phase. So that is not true. In fact, researchers showed that LH surges and FSH surges start from, in fact, before the menstruation. So from the luteal phase of the previous cycle. And even when your follicles are 8 or 10 mm, you can start having endogenous LH surges. And that is why that impairs the response and your final outcome of top quality embryos. So that is why 14 mm is not the right time to start, because almost 40 to 50% of patients will have small surges even before 14 mm is reached. And that is why the recommendation is to have a fixed day start on day 5 of gonadotropins.
Right, sir. Can ovarian stimulation be done for egg freezing in poor responder patient with Mirena in situ? Because the Mirena inserted for severe pain due to adenomyosis 4 months back with no pain presently.
Yeah, so I think because Mirena is a progesterone release, so we don't really know because there's not enough research on that. But since it's a local release only affecting the endometrium and the systemic absorption is very less, I think you can go ahead with retrieval, should not be a problem. And now, especially with dual stimulation, like, when we do a luteal phase stimulation, there will be high progesterone levels because of the follicular phase corpora lutea, which are there. And still we get such good quality oocytes. So I don't think a Mirena will really affect the outcome in oocyte freezing.
So they are again asking regarding the usage of testosterone gel, how to use, and just to elaborate, sir, how can we use that testosterone
So
gel?
you have to give it for 21 days. Normally we start on day 5 or day 6 of the preceding cycle. And then when we start FSH on day 2, we stop giving the gel. So usually it's around 21 days. As I showed you, most of the international studies are for 2 to 3 weeks, except that one paper I showed you which gives for 4 weeks. So right now we are sticking to the 21-day protocol.
Correct.
So day 6 of preceding cycle till day 2 when you begin FSH.
Right. Can we give methoxyprogesterone acetate in duostim in follicular as well as luteal stimulation instead of giving antagonist from fixed day 5?
Yes, that's a very good question. There is a paper already on this, and I also said it that these are the challenges for the future. But definitely you can use MPA throughout the cycle and not use antagonist at all. In fact, there is now a publication which says that you don't need any analog in the luteal phase because you don't have any more endogenous FSH-LH or whatever which can cause surges there. So they are saying just in the follicular phase you use antagonist or MPA, and in the luteal phase you don't use any antagonist whatsoever, and you will not have a premature LH surge.
Right, sir. And any role of DHEA pre-treatment in endometriosis patient with poor reserve?
Yeah, as I told you, because initial Gleicher and all reported very huge benefits with DHEA. All of us started giving 3 months to all poor responders, whether endometriosis or otherwise. But Wang and all, there are 3 large RCTs now, which show that there is not enough evidence to support its routine use. So it's a debate there, how effective it really was. And but if you personally have good experience with it, it's always worthwhile trying because there are no significant or major side effects with the use of 2 to 3 months of DHEA.
And sir, in endometriosis patient, how do we optimize the oocyte quality?
So I would recommend that, we keep hearing that you have to use long protocol, but endometriosis, suppose the point is to use the long protocol in the frozen transfer. So in the frozen transfer, you need to give leuprolide suppression with a depot preparation and then go ahead to suppress endometriotic activity. But for the actual retrieval, your choice between antagonist and agonist would be guided by the AMH level purely. So that is how you should go about stimulating the endometriosis patients.
And sir, should we use long protocol in poor responder and normal responder, and
yes,
antagonist in hyper responders?
Yes, correct. So that is perfectly put. But in normal responders, you have to be careful because suppose you have a normal responder with an AMH of 3 and she's only 28-year-old and she's very thin and lean, then even with the long protocol, you are likely to end up with hyperstimulation. So you need to have your clinical judgment intact. That if you have to see all these parameters before you select the protocol, because the AMH of 3 would classify as a normal responder and not a PCO patient, right? But sometimes they can respond excessively. So you have to be very clear. Normally we keep a cutoff about 2.5. All below 2.5 AMH, we use long agonist protocol. About 2.5, we take into consideration the BMI, the age, previous response, and then decide between agonist and antagonist.
Right, sir. And the last question, for poor responder, should we freeze or fresh transfer?
So there is a debate here. There is enough evidence now. That's why I said that if your progesterone on the day of HCG, if you are a believer in the progesterone theory, is between 0.5 and 1.5, and you have got 1 or 2 top quality embryos, and the endometrium is a beautiful triple line, say between 8 to 12 with good blood flow, you could go ahead with a fresh transfer and expect the same pregnancy rate. The problem with poor responders is that more often you don't get that many top quality embryos in one round of stimulation. So suppose you have only one good embryo, I would rather freeze it, do a second round, again get 1 or 2. And once I have at least 2 top quality embryos, then I would go ahead with the transfer as a frozen transfer. So it all depends on the HCG levels, the endometrium, the blood flow, and the number of top quality embryos that you have.
Right, sir. So thank you, sir. On behalf of viewers and interns, you have given a brilliant lecture, and viewers are congratulating you, and they are very, very much satisfied. And again, we thank you for your time. And
thank you, Sunil.
Thank you, sir. Thank you. Thank you always for the amazing lecture which you have. And you know, the beauty about your lecture is you condense everything. Into 1 hour, which is a tough job. So what you actually do is, I'll be honest with you, which I think is the most important thing. You make a very difficult thing very simple. So I also personally, I always feel that all that you need to have in one slide is 4 or 5 papers simplified, which you do always, which is so beautiful. Thank you.
Thank you.
Thank you, sir. So with this, we'll start with Dr. Sunil Jindal sir's webinar that is on optimizing. Now we'll listen how do we optimize sperm in IVF ICSI. Over to you, sir.
Thank you, Dr. Sonal, and thank you, Dr. Jatin, for being here. And the beauty about IVF or fertility is that you've got to optimize everything from the sperm to the ovum to the laboratory. And that beautiful slide which Dr. Jatin had in the end, that you've got to optimize just everything. So the sperm is a very important part of the whole story. And in the first, I would say, in the first lecture of the series, we had natural and we had IUI. So the IVF washing part and everything, the medical treatment I have covered. So I think now I'd like to cover the other part of it, which is the azuspermia and severe oligospermia part of it. And I'd like to cover the clinical, the surgical, as well as the laboratory aspects to optimize the sperm. Because incidentally, God is kind, I do all the 3. So I just like to bring in the next 40-45 minutes, very quickly, everything the way it would be. So I'd like to share my screen. So optimizing sperm for IVF and ICSI, which becomes extremely important. And we have spoken all about this in the last lecture. But the important thing for us to understand is that the values of a semen analysis have a very acceptable specificity, but very low sensitivity for identifying male subfertility. Therefore, whenever you're interpreting a semen analysis, it needs to be interpreted with caution, and the functionality of the sperm becomes very important in this. So 3 basic things which today optimize the sperm not only naturally, but the functionality. We would like to get 3 basic tests, so there are a lot of tests, is the sperm DNA integrity, about which we'll have a separate lecture, the reactive oxygen species, and the Y chromosome microdeletion. Now, sperm DNA fragmentation, last time we spoke about the background, why we want to get it done, what's the principle. The specimen, of course, is the semen, and you could do the halo test or the tunnel test. But one thing which I'd like to bring out to you now, which is most important, is it needs to be done either on a fresh sample or it should be done on a thawed sample, immediately thawed sample. So in case you're sending your samples to a laboratory, they should be frozen samples which you are sending. Now, Y chromosome microdeletion,
very important in oligospermic and azoospermics because of the prime reason that it is linked to spermatogenic failure. And in case the specimen taken is the peripheral blood, the principle is PCR long arm of Y chromosome, severe oligospermia. And this is one of the causes of genetic, I would say, azoospermia. And you need to see that in the AZA area, B area, and C area, there is no retrievable sperm. So very in a nutshell, I'm giving three important investigations we have to think about. So azoospermia primarily is obstructive or non-obstructive. And about 1 to 3% of male population and 10 to 15% of male infertility is caused by azoospermia. So it's a very big number, very big number. Now, obstructive azuspermia, we all know, is when sperms are being produced, but they're not coming out. And non-obstructive is when there's a deficiency in the sperm production or it is absent. Now, this is a very beautiful algorithm for us to understand that in obstructive azuspermia, you normally would have a normal size testes, an endocrine profile, and mechanical blockage, and so the spermatogenesis is normal. And in a non-obstructive azospermia, there can be two things. It can be either a spermatogenic failure, where the FSH, LH are high, testosterone is low or normal, and the testes can be small or normal. And in hypogonadotrophic hypogonadism, the FSH and LH level is less than 1.2. Testes are small, testosterone is less, there is poor virilization. So spermatogenesis is disrupted in non-obstructive azospermia. So I'm showing you two algorithms, beautiful algorithms they are, that in case the semen is less than 1 ml and the pH is less than 6.5, which means it's an acidic sample, do a physical examination. If they are palpable VAS on both sides, do a transrectal ultrasonography. In case there is a blockage, by doing a transurethral resection, you probably would be able to open up the ducts. And in case there is congenital absence of both the vas deferens and this absent vas deferens bilaterally, get a CFTR mutation done, husband to diagnose, and wife, of course, if you're using a donor sperm, and you would like to surgically harvest the sperms. Now, if you get in a system where you have a normal volume sample and the pH is more than 7, it can be two things. It can be a normal FSH or a high FSH. If there is a high or a low FSH, it can be three things. It can be a low FSH with a low LH and a low testosterone, which is hypogonadotrophic hypogonadism. Or it can be low FSH, low LH, high testosterone, which we see so often whenever people take anabolic steroids. Or it can be high FSH, LH plus minus, testosterone plus minus, which is a non-obstructive azospermia. You'll have small testes. They can be softer in consistency, and you need to get a Y chromosome microdeletion and a karyotype. So the other is when the normal FSH is there, the testes is normal, the epididymis is full, it is an obstructive azospermia. You can do reconstructive microsurgery, or you could do a TSA. You could surgically harvest these sperms if reconstruction is not possible. So I've just given you a gist, and now I'll just talk about the sperm retrieval techniques and which is to be used where. See, a PISA is percutaneous epididymal sperm aspiration, which is done in an obstructive azospermia. Microsurgical epididymal sperm aspiration is done in an obstructive azospermia. Now, what is the advantage of doing a MISA? The advantage is that when you microsurgically open up the epididymis and you take out sperms from the tubule, you get a very large quantity of clear sperms. So you get a very, very good harvesting in an obstructive azospermia. I'll also show you a video of an obstructive azospermia epididymal tubules, and you'll be able to really identify and understand of how important it can be. Now, you may need to do a TISA. TISA is a testicular sperm aspiration. You do a TISA when there's a failed PISA in obstructive azospermia. There is epididymal agenesis and epididymis is not felt. And there is a favorable testicular histopathology in non-obstructive azospermia or previously successful TISA attempt in non-obstructive azospermia. While TISA, which is like a testicular biopsy, if it's a single or multiple, is done in a failed PISA-TISA in obstructive azospermia, non-obstructive azospermia. But something which is most important for us to understand is microsurgical testicular sperm retraction, micro-TISA. And micro-TISA is done in non-obstructive azospermia. A lot of people ask me, and I'll show you all the videos, I'll explain everything to you. A lot of people ask me that which microscope do I have to buy for a micro-TISA? So I always tell them what you need to learn is microsurgery. It's a totally different way of operating. And you need to know how to do microsurgery. The microscope gives you nothing. One. And another thing which, in fact, one of my mentors, he's no more, Dr. Rakesh Sinha, used to say that you need two things to do to be good in a craft: patience and patience. So you need a lot of patience for the learning curve, and you need a lot of patience because at times it takes up to 1.5 to 2 hours to get out a sperm. And well, it needs patience also at the end of the embryologist. So these are two things which are needed. So I'll just show you PISA. So PISA is done on the epididymis. And the trick for doing a good PISA is when you are able to get to the turgid area of the epididymis. So you need to feel the epididymis, feel the turgid area, and you normally would use a 24 gauge needle with a BD syringe like over here. And you need to have some media present in the syringe. The fact remains that though it may appear to be a very simple procedure, it's not a complicated procedure, but you need to have a fair idea about the feel of the epididymis because it's a procedure of feel. Now, at times what happens is, now this is what I was trying to show you, that this is the way epididymal tubules look. This is how you see them when they are dilated. And when you do a MESA in one of them, you open up one tubule and you suck out the material. My God, you get the greatest harvest possible. There is another advantage of doing a MESA. The moment you put in a needle into the epididymis, you are blocking the whole epididymis completely for life because it's a single tubule which has formed the epididymis. The moment you put in a needle and you disrupt it, the continuation is gone. So if ever, because of some reason or reconstruction, you think that the sperms would come out ever in the ejaculatory duct, they will not if you've done a PISA. So this is one thing for us to always understand. Now, what this is, the print is wrong. It's a PISA, and this PISA is normally done with a 21 gauge butterfly. So you would like to take a butterfly if the BD syringe has not given you, and you're going to have the tube which has a media. You're going to clamp the tube, and once you have clamped the tube, the suction is maintained, and then the material which you get, you will put it into a petri dish, and this is going to be sent immediately for to the embryologist. Now, how do you process a PISA? This is very interesting. So what you need to do is, I brought it over here, you need to homogenize in the sperm media to prevent any kind of agglutination. And you need to inform the surgeon the moment sperms are seen. Identify the site of retrieval and note it. And in case these sperms are good, you can use the native sample. And this native sample can be diluted in sperm medium, or it can be washed in a sperm gradient medium. Now, PISA sperm processing. Now, this is a plate which normally we make. And in this, normally we would have over here a well where we're going to put in the spread the aspirate. And from this aspirate, in case it is less, we will take out all these sperms from the periphery and put them into the PVP. From there, we would immobilize these sperms, aspirate them, and inject them into the metaphase 2 oocytes. Next, we come to TISA. See, TISA is done in a failed PISA. You would normally use a 17 gauge needle to a 19 to 20 gauge needle. You would use a 10 or a 20 ml syringe. I think the printing is wrong over here. And you would take the testes, place it in, pulverize an area, use a 20 ml suction, and with the 20 ml suction, you would like to take out whatever material comes into the thick needle and the hub of the needle. Once it is out, you would like to use a micro, in case there is a seminiferous tubule which comes out, you'd like to use a micro forceps to pull out the seminiferous tubule if possible. So I've talked to you about a TISA, but how do you process the sample? So the processing is very important. You'll like to perform a mechanical dispersion using 2 needles, and the homogenate is either washed in sperm media, or it could be the aspirate and transfer could be done directly, or it can be washed. And consider freezing always of the aspirate which is left over. What we normally do is we incubate this for about half an hour to 2 hours so that we could get some kind of a motility in these sperms. So in Obstructive Azuspermia, this is a beautiful paper by Sandro, in which if you see over here, that sperm retrieval is above 95% in most of the cases in Obstructive Azuspermia. You may need to do PISA, you may need to do a TISA, but in any case, about the retrieval is very good. The other thing is that the outcome of the ejaculated sperm and the epididymal or testicular sperm in terms of fertilization, in terms of pregnancy, is about the same. In fact, it is a bit better with epididymal and testicular sperm, though not surgically, I would say, clinically significant, statistically significant. But yes, it is very good. And another thing which happens is that most of the women of azospermic men with obstructive azospermia are young and at times free of any kind of tuberculosis, endometriosis, or any kind of a disease. So it becomes very good. And they're very good oocytes. They are waiting for these sperm. So the success is very good. Over here, if you compare obstructive azospermia with fertile donors, it's about the same. So in obstructive azospermia, a retrieved sperm is as good as an ejaculated sperm. So the differential diagnosis, now just understand one thing. The importance of clinically diagnosing obstructive azospermia from non-obstructive azospermia is of prime importance. Now, 2 things I always say. Whenever a patient comes to you with azospermia, you need to examine a pelleted semen. You've got to centrifuge it and differentiate between true azospermia and cryptozoospermia. First thing. And the second thing is you need a minimum of 2 samples for the job, because please do not diagnose on the basis of 1 sample. This is the algorithm I have spoken to you about. Now, what is the current scenario of the type of patients which we get? So we get about 3% who are hypo-hypo, 36% who are obstructive azospermia, and the rest would be about spermatogenic failure, which is a larger number. And the second important step after diagnosis is counseling. Now, counseling is the most important part because we also need to get these people tested genetically. If there is no VAS, you've got to get a genetic testing done. Non-obstructive azospermia, get a genetic testing done. You've got to counsel. You also have to counsel them transparently of the expectation of the sperm which would be retrieved. You also need to counsel these people about what will be the success rate most probably, because in non-obstructive azospermia, the fertilization rate as well as the implantation rate is lower. So what is the etiology? Now, one thing for sure, etiology really is unreliable. So if somebody says you that because of this reason, the sperm retrieval will be high, no, it is not like that. The etiology is quite unreliable to counsel the patient. Now, when you select a patient, is there any biomarker to optimize of the way you would get it? So the biomarker could be an FSH level, the testosterone level, and the testosterone volume. If there has been a histopathology which has been done previously, well, if there is hypospermatogenesis with a micro-T, say you're going to get about 100%. Maturation arrest about 40%, and Sertoli only about 20%. But this is in very good hands, because please understand, this whole procedure of micro-T is completely operator and embryologist dependent, and both have to run hand in hand. So the third thing is in the management is the selection of sperm retrieval candidates who may benefit from the intervention of sperm retrieval. So what do you do before you take a patient up for a micro-T in non-obstructive azospermia? You would need, you need to understand that the intratesticular testosterone is very essential for spermatogenesis, of course, in combination with the FSH. And in case it is less, then spermatogenesis may be poor. So sperm retrieval success rates suboptimal in non-obstructive azospermia. So optimization of testosterone may increase success rate. Though literature is, I would say, conflicting, but I would normally always get a testosterone too close to normal before I would do a micro-T. So there is low quality evidence indicating that the hormonal therapy might increase sperm production and sperm retrieval rates, but this is the way the literature is. But you can give these people clomiphene, you can give these people aromatase inhibitors, you can give them HCG. In fact, this is one of the, it's a very beautiful paper where the increased intratesticular testosterone levels and spermatogonial DNA synthesis after HCG therapy has been studied. And it's been seen that before therapy and after therapy, it's a clinically and statistically very, very significant. So spermatogonial DNA synthesis goes up phenomenally when the testosterone is normal. So what all can you do? You can start HCG 1000 to 1500 international units twice a week. You would normally have to give it for about 3 months. You can adjust the testosterone between 500 or 800, but it should be at least more than 350 or 400. Add aromatase inhibitors if the TE ratio is less than 10, and add FSH if the FSH level, add FSH if the FSH level falls down below 1.5 international units per liter. You know, why is it important? I'll just explain to you that whenever you start giving these patients HCG, the FSH starts dropping. So these are the patients in which you may have to add FSH. Varicocele. The outcome of varicocele repair in men with non-obstructive azuspermia, there's a very big review. And 18 studies have been included in this. And it's been found that 44% had post-operative sperm return in the ejaculate. And histopathologically, the only prognostic factor for sperm return to ejaculate was hypospermatogenesis, maturation arrest, and Sertoli only. But just understand that if there is hypospermatogenesis, there is a chance of better retrieval if varicocele has been operated. So varicocele repair may improve spermatogenesis and androgen production, but we need to do in these patients a microsurgical repair, saving the spermatic artery so that the blood supply to the testes is not compromised. And varicocele is found in about 5% of men with non-obstructive azuspermia. So the step 4 is application of the most effective and efficient surgical method for sperm retrieval. So in case, this is just the data which I'm bringing in front of you, in case you do a testicular sperm aspiration, the chances are about 15 to 50%. Testicular biopsy would be 20 to 60%, while a microdissection testicular sperm extraction would have about 40 to 67% chances of retrieval. So micro TCA has about 1.5 times more likely to result in successful sperm retrieval than conventional TCA. And the 5th step is utilization of appropriate laboratory techniques for handling retrieved gametes and cultivating embryos resulting from ICSI. So this is a very detailed slide, but I'd just like to just highlight a few things. Now, whenever you do the testicular tissue handling, if there is very little amount of tissue like in micro TCA, you would really like to process it well. It could be either mechanical mincing, which we do most of the times. It could be enzymatic mincing, where we use collagenized type 4 as well as DNAs. And we also see what we normally do is we normally clean it with spermatic media. And what we do is we incubate. Because of this, what happens is that the RBCs get lysed. And at times we need to use pentoxifylline. Whenever we have most sperms which are non-motile in them. Of course, Dr. Jatin Shah had spoken about the laboratory environment, which is also needed for this sperm. And cryopreservation is very important in these sperms which are left over or which can be saved. So the classical sperm selection would be by swim up, density gradient. However, now I just like to bring in a few things that supposing these sperms, all the procedures which have come up in those sperms, which are very less in number, IMSI, PICSI, and I'm just wanting to touch them for a minute. I will not go into the details. So in IMSI, which is magnifying the sperm in the laboratory, there is good scientific evidences which are available. Now, the cost of the equipment is expensive. Embryologist training is difficult and it's very time consuming. PICSI, limited to micromanipulation, insufficient data, electrophoresis, they get hold of negatively charged cells. There is improved DNA quality. However, there is insufficient data. Birefringence is the light deviation which takes place, limited again to micromanipulation. There is insufficient data. And microfluidics talks about the motility of the sperm. And only the motility-based sperm selection. And again, there is very limited data. If you look at the advanced sperm evaluation methods, they have not been considering cumulative rate as successes, not enough statistical power, lack of independent studies, poor or low number of evidences, lack of generalizability and lack of consensus, expensive, only in a few patients. So the particular case of ART in medicine, I would feel that there are three components: the sperm, oocyte, and endometrium, and all three need to be optimized. And time is going to tell us which of these procedures is going to optimize sperm, especially in the very low number of sperms which we get. Now, sperm retrieval success, of course, is higher in microTC, and sperm freezing becomes a very important way in low volume carriers. So you could be doing it by the conventional way, you could be doing vitrification. There are also some cell sleepers or low volume carriers which have come, in which we have started freezing sperms of non-obstructive azuspermia. So I had spoken to you about it, but now I'll just show you the procedures. So please understand, in non-obstructive azuspermia, it's like a tree with apples. So when you open the testes, you've got to find the apples, which would be a few focal areas of spermatogenesis. So if you see over here, this is the testicular biopsy through a window technique. You would open the tunica, take out a small piece. All that would be required would, after good hemostasis, is a single stitch and a band-aid. So you can even do it under local anesthesia. Now, TC multiple incisions, this should be done in non-obstructive azuspermia if you do not do a micro TC, though it is not as effective as a micro TC. This was a patient who had come to us. It's a very, very old video. And this patient had come to us who had been operated earlier, and he had a lot of adhesions all over the tunica, and multiple incisions were given from different areas, with the idea that at least one area would be such from where we could get sperms. So how do you prepare these sperm? This is just a video which I'm trying to show you. So this is the testicular tissue. So this testicular tissue is minced, and this testicular tissue is literally homogenized. And once it is homogenized, from this homogeneous material, we would like to see under a microscope to get sperms. Now I'll show you two techniques which are very beautiful and amazing. So I have started using them before micro-TC. One of them is needle mapping. So what you do in the needle mapping is that you mark about 16 areas in the testes. And once you mark 16 areas in the testes, you would normally do a TISA in each area, have 16 drops, place each aspiration into a drop, and send it to the laboratory. In case you get sufficient sperms, great. And if you do not get sufficient sperms, then you have an understanding which is the area in the testicle from where you would be able to get sperms. So this is what needle mapping would be. And when we normally do a TISA mapping, this is very interesting. See, this is the testes in which we were to do, example, microdissection. So before that, if you mark over the equator 8 areas above and 8 areas below, and you do the same TISA procedure or a needle aspiration, when you take out the needle with the pressure maintained, you're going to have a few seminiferous tubules. And these seminiferous tubules, if you start pulling out, you get a very interesting chunk of tissue. So this chunk of tissue is taken out from the 16 areas, and normally it is sufficient to have enough sperms. And if you do not give enough sperms, you go ahead for a micro-TSA. So micro-TSA is a beautiful procedure. And I do it under general anesthesia. Do not use any betadine. It is cell toxic. You give a large mid-portion incision in the testes, and the testicular parenchyma is widely exposed. You need a magnification under a microscope. Loop magnification is not enough. And the magnification is about 15 to 25x. And any enlarged tubules which you find need to be removed. And if they are not enlarged, they could be of a different shape and color. And if the tubules are identical, then you would need to take some random biopsies. But if you put yourself into it, then after about, you've got to give yourself some time. You've got to, like I fixed a time for myself of about 1 hour, 15 minutes per testes. If after 1 hour, 15 minutes, I do not get a sperm, then I would probably call it a day. But otherwise, if you go on, you normally would be able to get a sperm. But it's very, very, there's a lot of patience which is needed by the embryologist as well. So I'll just show you over here a micro dissection. So what normally this is when very superficially we've just opened. And after opening up the area, we would like to see under a microscope. And any areas where we would feel that the seminiferous tubules are larger, thicker, we would like to take them out and give them to be taken to the laboratory. Simultaneously, you have the embryologist looking into the tissue. It cannot happen that you've given. And the beauty about India is it's possible. When I went to a few centers in the United States, I realized it was very difficult for them to fix the theater time with the laboratory time. So this is where you've opened up the testes further and you've splayed open the whole testicular tissue, and it closes back beautifully. And in fact, the reconstruction, you don't have to do much. All that you have to do is close the tunica. And this is how in Eppendorf tubes, the tissue is going to be given to the laboratory. This is how it would appear in a particular area, a few tubules which would be larger and thicker. So this is how the sperms would look in a testicular sample, which need to be taken out. Now, the processing of a TSA sample is just like the TSA sample I had spoken to you about. You put them in a sperm media, wash the blood clots, mechanically disperse using tuberculin syringes until no intact tubule is found, transfer raw suspension, and depending on the concentration, motility, and debris, either use directly, wash them, resuspend, or use a density gradient. Leave sperms to be incubated. Now I'm just showing you the different types of plates which we make. So this is a spread. If it is very poor, then we probably would put the sperms over here, look for sperms here and bring them into these 2 drops. If we feel we would get them, then what we do is we normally would place them here, the spread, find sperms, put them into this drop, and then from this drop, take them into the PVP. And the third is where in a PISA sample, we know sperms would be there. We place them over here, put them into the drop, put them into the PVP, and inject them into the oocytes. Now, supposing you have sperms which are immotile, and you've got to look for the viability of these sperms. So there are different strategies to identify. What we normally do is a horse test, or we would do in these sperms a sperm tail flexibility test. You take the sperm in, sperm out, sperm in, sperm out. And in case flexibility is there, you would know there is a viability. And motility stimulants like pentoxifylline are also there. So again, I had spoken to you about the spread which you would make. You could have a spread over here. And in this spread, put all these sperms if it's very poor and get them into the drops and not have oocytes over here. And then from these drops, put them into the PVP. Or you could have a spread from here, you would take them into the drops and then take them into the PVP. Now, sperm, I'm just trying to show you this is a good sample. This is how after a direct inoculation, it would appear to be. So what you would normally get over here would be a sperm which you would look for. And if you're able to find a sperm with motility, it's a very old video, and a very old recording. So you would carry the sperm and inject the oocyte with the sperm. You would aspirate the cytoplasm, a bit of it, and then inject the sperm. So that's it. So it's a beautiful procedure, believe me, to be able to get sperms from the testes and make babies, and for people to have children is amazing. So I've spoken to you about the therapy which can be given. Hypogonadotrophic hypogonadism. I've always mentioned this case I had initially. Now I've had a lot of patients. I've spoken to it earlier. 26-year-old, 4 years of marriage, small volume testes, low FSH, low LH, testosterone low, gave him testosterone, testicular size came back, testosterone came back, started HMG, got sperms in about 4 months. First cycle did not have any pregnancy. Second cycles we transferred 4. It was a long time back, about 14 years back. So we transferred 4 with the idea something should be there, had quadruplets, did a fetal reduction, gave birth to 2 beautiful twins. So for the last, I think it's about 10 or 12 or 14 years, I don't remember exactly. From that time till now, we've had so many people of hypogonadotrophic hypogonadism who've had their own children. Well, the future optimization of sperm, testicular biopsy, tissue could be taken. This could be xenotransplanted into a mouse to get sperms. Organ culture of spermatogonial stem cells could be done. There could be an auto transplant. Spermatogonial stem cells could be cultured to get sperms. A skin biopsy could be taken. And in the future, a skin biopsy could be used as a pluripotent stem cell to get sperms. We really do not know what will happen. But we know one thing for sure, that in case sperms need to be frozen, they need to be frozen, and that's the best way to optimize sperm in a lot of people, like people who are going to get chemotherapy, older age group people, people going for war, or people who we know for sure have a very low sperm count, and this sperm count, well, needs to be frozen. These sperms need to be frozen. Spermatogonial stem cells, in the future, in mice, it has been done. Spermatogonial stem cells have been cultured into sperms. Microinsemination has been done, and mice have been born. It has not been done in humans till now because the tissue culture has not been, I would not say perfected, but there are a lot of problems with it. And to get spermatogonial stem cells from a testicle, a lot of tissue of the testicle is needed, which I don't really know how much will be permissible and how much will be possible. CRISPR is a great technology where the sequence of DNA is substituted by another sequence in the embryo. So I do not know in the future if designer babies would be born. Well, a team full of Sachin Tendulkars and a team full of, I would say, any kind of player or the most intelligent people in the world could be there. But I think ultimately it's going to be used for couples who want a baby free of thalassemia, free of diabetes, where the genes could be changed. And this would be beautiful technology. And something to think about, I always get this slide because I find it extremely interesting, that till now a sperm and an oocyte is optimized for a baby. In the future, when 2 men get married and 1 pluripotent stem cell could be converted into an oocyte with the sperm, could be optimized to have a baby. And if 2 women get married and they want a baby, a pluripotent stem cell could be taken and made into a sperm, and one could carry the baby, but the only problem is they'll probably never be able to have a male baby. So with this, I'd end the presentation. Thank you very much. Thank you so much for your patience. It has been amazing to have you with us, and thank you for taking out your time. I hope whatever I have spoken today would be valuable. Thank you very much.
Thank you, Jindal sir, for giving a very insightful, practical, and amazing lecture with very nice videos. It was we were very excited to see it, and with clear take-home messages. There are few questions. They are asking, sir, is there any single marker for sperm quality? Is it DNA fragmentation test or?
There is something which I would say is the functionality. Vinod, can you please off your audio, please? Okay, off your audio. Yeah. So what happens is that one is the number of the sperm, which you get from a semen analysis, and the other would be the functionality of the sperm. So the idea about the functionality of the sperm would either be judged from the redox potential, which is the ROS value, or it can be judged by a DNA fragmentation. So these are two tests which would tell us about the functionality of the sperm.
Regarding, they are again asking, can you, sir, advise us on sperm DNA fragmentation test and how do we use it, when to use?
I'll have a very long lecture on it. Sonal madam, the next lecture is going to be on DNA fragmentation. I've had with Dr. Ashok Agarwal, there's a beautiful review article. It's a very thick review article, 55 pages. And incidentally, I was a part of that whole review article. Right. And it is something which really needs to be understood by every clinician. But sperm DNA fragmentation today, the best available tests would be either the tunnel test or the comet test, which are not really possible with the volume you have in a setup first. So what probably you could do is use a halo test, but that too needs to be standardized very well in your laboratory first. Second thing is you cannot send a sample because you'll have to freeze the sample in liquid nitrogen, send it, and they'll have to thaw it and do it immediately. That's one issue and one catch with the DNA fragmentation test.
One question is, sir, you discussed about usage of gonadotropin before sperm retrieval surgery. Should we use FSH as per the level of testosterone also?
See, I think I'll just explain it to you.
Right.
If the testosterone is low, then you need to give the patient either clomiphene. If the T ratio is not correct, an estradiol, or you can give the patient HCG. Now, if the FSH is already high, as would be there in non-obstructive azuspermia, there is no really point of giving FSH to these people. However, if you give HCG for some time, the FSH may come down. And if it comes down less than 1.5, then you need to give FSH.
And they're asking, till what time should we continue HCG?
The effect of HCG would be in at least 3 months. So you need to give them for at least 3 months and then do a sperm retrieval.
Right, sir. And another question again on gonadotropin therapy in hypogonadal patient. Sir, further you can, for us to understand, can you elaborate it?
Hypogonadotrophic hypogonadism, depending on the body weight, you're going to give HCG to these people. When you give HCG to these people, the testicles, the intratesticular testosterone will improve, the blood testosterone will improve. You're going to see the testicular size. Every month, you're going to do an FSH, LH, and testosterone. When the testosterone level reaches above 350, you're going to start HMG or FSH for these people. And once you have started that, you've got to wait for 4 to 5 months.
for sperms to appear. At times, these sperms would appear in up to 6 months or 8 months. I've had patients in whom these sperms have not appeared, and I did a testicular, a micro TC, and I got sperms. So you've got to understand those sperms come in most of them, but there are few patients in whom sperms would not come. When they do not come, you've got to speak to them about retrieval of sperms, if at all. That's a small subset.
And when you start FSH, do you HMG? Do you continue HCG?
Of course.
Yes.
No. Yeah, of course. HCG needs to be continued throughout.
Right, sir. And again, one question regarding the usage of antioxidants. Do you use antioxidant, and which do you recommend?
I use loads of antioxidants, and I've had patients who were with very low sperm counts, all sperms non-viable. And I did a horse test, did not find any sperms, told them we'd like to use a donor sperm, said, no, please try, put the patient onto antioxidants, got a few viable sperms. I've had patients with very poor, long patients coming to us with a lot of IUI failures, and these patients, IVF failures, did DNA fragmentation high, gave them antioxidants, took them on. Now the question is, which antioxidants? There are some beautiful review articles. There is one beautiful review article by Dr. Ashok Agarwal, and this review article brings in all the antioxidants, and most of the antioxidants have two things which need to be understood. One is, if given in a subnormal quantity, they don't act. So most of the preparations which you get in the market are suboptimal. They would tell you there is coenzyme Q, vitamin A, vitamin C, XXXXXXXXX, and in that one tablet, it's suboptimal. So it will not work. And most of these antioxidants work on different aspects of sperm development. So they are complementary. So by your saying you will give one, it will matter? No. So I think, Sonal madam, you're going to organize a program on sperm DNA fragmentation and one program on antioxidants. And if Mr. Satpathy will be able to get Dr. Ashok Agarwal for people, I think it would be so useful.
Sure. Sure. So with this, we thank you, sir. All the viewers have thanked you a lot, and they are very pleased to have you and listen to you. On behalf of Intas, I thank you again. Vinod is there.
Hello, sir.
Hello. Thank you very much. All the people who were here to listen to us, because let me be honest with you, you could be doing anything else, but you decided to be here. And I hope I was able to give you something for your patients which you could utilize and help your patients. And in terms, well, do a greater job. So thank you very much. We're going to have one more lecture, if possible, after this in the third masterclass, which we're going to speak about. I'm talking to Dr. Jatin Shah about it. If we could talk about lifestyle, holistic fertility for the ova and the sperm, I think that should be fantastic.
Yes.
So I think the third lecture, if things crystallize, would be there. And in case they crystallize, we'd love to have you with us. Thank you very much.